Within this module, we will work on our understanding of how quality is defined both generally and within EMS. Once completed with this module, you should be able to create a quality standard for use within your own organization, identify quality standards in the EMS industry and profession, match organizational performance with national standards for clinical care, map and define quality using a variety of management tools, diagrams, and other processes, and differentiate between a performance measure, indicator, and benchmark. So what would you do in the following scenario? One of your crews responded to a frequent system user with a history of sickle cell anemia. Your personnel are very familiar with this patient, and many consider him to be a drug seeker. On this particular evening, one of your crews was somewhat belligerent with this patient given his frequent use of the system and his history of opiate abuse. No vital signs were taken, and the patient eventually signed a release. Only about an hour later, however, a different crew responded to the same patient with a very different outcome. Treatment and transport was provided following your agency's chest pain protocol. It turns out the patient was presenting with ST elevation in leads 2, 3, and AVF, which was indicative of a myocardial infarct. This second crew not only identified a potentially life-threatening emergency, but was following up with the emergency department physician regarding the pathophysiology that increases the patient's risk for an MI given his sickle cell crisis this evening. In evaluating this scenario, do you believe the initial crew provided quality care? If not, what aspect of quality care failed in this instance? How is quality defined for this type of patient? What type of errors were experienced here? What type of key indicator could be created or already exists for this patient? Far too often, EMS providers fail to recognize that EMS is a business. EMS agencies have resources, budgets, expenses, revenues, stakeholders, and customers. While most EMS providers probably have an inherent understanding of the mission, vision, values, and goals of their organization, it is important for these elements to be defined in absolute terms for everyone to review. In doing so, the EMS agency will define itself and what it does, which then allows the agency to also define quality as an organization. By defining quality, the level of quality desired, and how quality will be measured, the organization can focus members on organizational goals, jumpstart change initiatives, and energize improvement activities. At its most basic level, a quality improvement system strives to ensure the right things are done right away. Part of the goal of a quality improvement system is to also eliminate waste. Waste costs money and resources. Waste also contributes to errors and bad outcomes. Thus, continuous quality improvement techniques seek to eliminate activities that do not add value to the process of providing quality. Stated inversely, quality organizations seek to invest their time, money, and resources in value-added activities. While quality within an EMS organization can be impacted by numerous factors, the providers of emergency care themselves are obviously integral to ensuring quality delivery of services. With regard to EMS providers, an employer must first adopt the mindset that its employees want to do the right things for the right reasons. Within EMS, this is referred to as a just culture. Far too often, it is easy to jump right into discipline by assuming the employee had some type of bad intent. For a quality improvement system to really be effective, the employer must assume the employees are always acting in good faith. With that in mind, the quality improvement process must look at the employer's systems and evaluate how they can be structured to achieve quality and support its good employees. Continuous quality improvement activities must encompass the entire organization. This begins with the organization's mission, vision, values, and goals before extending to the domains of quality, structure, processes, and outcomes. Ultimately, when a holistic quality appraisal is conducted of an EMS agency, there are essentially 5 areas of organizational quality that must be benchmarked. The first is reputational quality. How is your organization viewed by other EMS agencies? What is your reputation within the profession itself? Does your EMS agency actually do what it says it does? The second area, image quality, is somewhat related to the first, but it casts a wider net to encompass your customers and stakeholders. Is the EMS agency's brand identifiable? Does the average taxpayer or potential customer recognize the difference between your ambulance and one owned by a neighboring community or competitor? Are your staff considered professional? What is your reputation not with other EMS agencies, but with the community as a whole? Third is service quality. This is directly related to the customer service experience. If you were to ask a patient, taxpayer, or other stakeholder what they thought of the quality of services provided by your EMS agency, what would they say? What is the perception of the overall experience for customer, patient, or the public? Do they perceive your services as quality services? The fourth area is technical quality. This refers to the care provided by the EMS agency. Was the provided care competent, appropriate, and evidence-based? Lastly, the service must benchmark operational quality. How efficient is the billing process? How is your equipment maintained? Are your response times reasonable? These are all critical areas to consider when defining and evaluating quality within an EMS organization. One of the first quality measures an EMS agency needs to consider is related to public expectations of that service. Namely, the public expects a timely and competent response. To meet this need, EMS leaders must examine both the strengths and weaknesses of the agency and make modification as necessary to meet that public demand, which means the EMS organization must have defined quality within its system. Without that definition, there can be no direction to achieve the organization's goals or direct quality improvement efforts. It is of critical importance that the EMS agency recognize that patients, the customers, not only want rapid and competent care, but they also want empathy, compassion, and to be treated like a person rather than just another patient. In many aspects of the patient experience, quality is about perception. How patients are treated, which begins with the first impression made by the EMS crew on that patient, can have a significant impact on that patient's perception of the quality of care provided. While we routinely refer to our patients as customers, also keep in mind that EMS agencies and providers have numerous varied customers, such as the patient's family and friends, local business and industry, other emergency responders, and other healthcare workers and agencies. Regardless of your focus in a quality initiative, however, the ultimate definition of quality is important for the success of any quality improvement efforts. To help healthcare agencies in defining quality, the Institute of Medicine developed something known as the focus method. First, the organization finds a process to improve. It then organizes an effort to work on improvement. This commonly begins by clarifying the current knowledge of the process, the current state. The group then works to understand the process variation and capability. Lastly, a strategy is selected for further improvement. This all feeds into the PDSA loop as a strategy for further improvement is implemented, studied, modified, and so on in a cycle of continuous improvement. At the onset, an organization developing a strategic quality plan should look at short-term, medium-term, and long-term organizational objectives. While the timeframes for these objectives can fluctuate from organization to organization, short-term objectives are routinely considered to take 3 years or less to accomplish. Anything that takes more than 5 years is often defined as a long-term objective, which is typically considered to be a part of the organization's vision, where the organization wants to be in the future. These timeframes are usually determined by the ability of the organization to implement change. Each objective should identify the ways to achieve those objectives and measure the effectiveness or impact of the changes on quality outcomes. It is also important that these objectives focus on ensuring customer, patient, and stakeholder satisfaction, which includes not only external stakeholders, but the people internal to the organization as well, which includes the EMS providers employed by the agency. Developing and defining quality in a strategic plan requires the use and analysis of information and data. This data should be used to drive benchmarks, processes, and goals that are included within the plan. From this information, the plan should delineate key processes and performance indicators. After all, how can you say a change resulted in an improvement if you do not have any data to prove it? That is what your performance indicators are for. They provide a measuring stick for your quality improvement initiatives. Within the healthcare field, there are 3 types of performance indicators used to measure quality in patient care: structural indicators, process indicators, and outcome indicators. Structural indicators consist of data or attributes that involve the setting in which care is provided. Such indicators include the defined components of an EMS system, such as facilities, equipment, staffing, provider knowledge base, credentialing, and deployment. In many instances, structural indicators utilize local, regional, or even national consensus standards. One criticism of structural indicators in EMS is that they are typically an indirect measure of quality that may not be directly related to actual outcomes in patient care. An example is that of response times. In most systems, it is fairly easy to compile response time data, and there are standards in place that stipulate how long it should take to respond to various emergencies a given percent of the time. Being on scene within 9 minutes of a 911 call 90% of the time may meet such a standard and sound impressive to elected officials, but it cannot be correlated to quality patient care and outcomes. Process indicators measure the ways in which program services and goods are provided. Within the EMS realm, process indicators provide a way to directly evaluate the components of the encounter between the pre-hospital provider and the patient. Being as how a process is a repeatable sequence of actions used across all EMS levels to produce good patient outcomes, process indicators allow for direct assessment of quality care. The inputs from process measures are usually easy to interpret and act on, yet increasing complexity in processes given increased clinical sophistication of the medical services provided in the pre-hospital setting can make such measures difficult to use. An example of a process indicator would be the evaluation of the performance of any EMS skill in compliance with an established procedure or protocol. A medical director can evaluate process indicators by running a provider through a controlled evaluation in a simulation lab or in reviewing patient care report documentation for process compliance. The last indicator is an outcome indicator, which evaluates the change in a patient's subsequent health status in response to a clinical intervention. It is a quantitative or qualitative measure that provides information about whether or not an outcome has been accomplished. Outcome indicators are often considered to be lagging indicators of quality because the data is routinely compiled after care has already been provided. If an outcome indicator finds a problem, that problem cannot be fixed in time to help the patients that were negatively impacted. Additionally, it is usually necessary to consider multiple outcome indicators together to evaluate quality, as a single outcome indicator on its own may not be very probative. Early defibrillation data in conjunction with neurologically intact discharge rates, for instance, helps paint a picture that neither data point would provide on its own. Another shortcoming of outcome data is that while it is usually easy to interpret and understand, it must also be linked to performance indicators, accurate risk assessment, standardization of definitions, and development of research models to be clinically relevant. As a start to defining quality, several themes must be incorporated into EMS operations. There are universal principles of quality that apply to all industries and, when boiled down into terms that make sense for healthcare and EMS by extension, can be summarized into 4 core areas of focus: patient or public, systems and processes, measurements, and teamwork. A focus on the patient or public recognizes that services must be designed to meet the needs and expectations of patients and communities. After all, that is who we as EMS providers are there to serve. Without these customers, there is no need for an EMS system. A focus on systems and processes recognizes that providers must understand the service delivery system and its key service processes before it is possible to improve them. A focus on measurements recognizes that data points are needed to analyze processes, identify problems, and measure performance. Lastly, a focus on teamwork recognizes that no one person is an island in the realm of quality improvement. Quality is best achieved through a team approach to problem solving and quality improvement. With these different areas of focus in mind, it is now time to revisit strategic planning in greater depth, along with its importance to EMS agencies. To begin, benchmarking is a common process used to perform self-evaluation and begin the strategic planning cycle. It is an ongoing and systematic process for measuring and comparing the work processes of one organization to those of another. Within the realm of EMS, this means comparing your agency's activities, functions, or operations to other EMS agencies. Benchmarking either compares performance of an indicator or establishes a level of performance that should be reached for a given structure, process, or outcome indicator. The goal is to provide a standard for measuring the quality and cost of internal activities and to help identify where opportunities for improvement can be made. The first step is internal benchmarking, which involves two-way communication and sharing of opinions between departments or areas within the same organization. This allows the organization to examine itself before comparison to other external entities. In a smaller EMS agency, different areas could simply mean a different crew, shift, or station. If any part of an organization has a better performance indicator, that information can be shared to evaluate and learn how the better performance indicator was achieved. These findings can then be used in subsequent external benchmarking activities. In external benchmarking, the organization takes the information it gathered during its internal benchmarking to discover new ideas, methods, products, and services by focusing on external EMS organizations. By way of definition, a benchmark is a standard against which something is measured. This is different from benchmarking, which is an improvement process by which an EMS agency measures its performance against others, determines how those comparison groups achieve their level of excellence or performance, and then applies that information to improve its own performance. In discussing benchmarks, it has proven difficult to generate a standard or common set of benchmarks given differences in individual systems that influence outcomes and performance indicators. Therefore, it is important for services to have an understanding of their respective performance indicators and any variance in practice that would impact somewhat similar performance indicators obtained from external benchmarking. With that background, it should be possible to evaluate any gaps in performance indicators from your service to those external agencies considered to be models of best practice and to take actions to work on closing that gap. Essentially, any aspect of an EMS organization can be benchmarked. Within that process, the EMS agency is searching for and copying new ideas and best practices for the improvement of processes, products, and services. There are many avenues for benchmarking, which includes literature reviews, consulting experts, identifying current practices, or replicating another agency's best practices. To narrow down the scope of benchmarking within an EMS organization, it is often helpful to break down possible benchmarks into different categories. The first such category includes operational benchmarks, which are those measurements against everything that affects the field operations of an EMS agency. This can include any process, procedure, or action that involves the support of the clinical application of EMS. It does not include the practice of medicine, however. Examples of processes that lend themselves to operational benchmarking include dispatch, fleet management, staffing, coverage, cost per unit hour, cardiac arrest survival rates, and work-related injuries, to name a few. The textbook provides additional examples. Another type of benchmark category includes clinical benchmarks. These benchmarks are established using process and outcome indicators, and they relate directly to the practice of medicine. Intubation success, pain control, trauma system outcomes, and stroke outcomes are all examples of clinical benchmarks. EMS agencies may also decide to compare business benchmarks to evaluate organizational efficiency. These benchmarks could include customer satisfaction ratings, vehicle reliability history, emergency department turnaround times, OSHA compliance, and employee absenteeism. Again, the textbook provides additional examples for you to review. There are also functional benchmarks based upon comparative research with recognized leaders in the profession or field. A fire service example would be comparing a fire department's level of customer service with the Phoenix Fire Department, an organization recognized for providing the pinnacle of customer service to their taxpayers. Even if your department is located nowhere near Phoenix geographically or in size or resources available, there can still be value in benchmarking against a recognized leader in customer service, or whatever performance indicator you want to improve. It is also possible to benchmark against organizations that are involved in a completely different industry as well. Businesses do this all the time. Your EMS agency may not be a direct competitor of Amazon, Google, Coca-Cola, or McDonald's, but there is still value in using those entities for benchmarking, depending on the scope of the review. Beyond functional benchmarking, regulatory or administrative agencies may choose to define benchmarks within a specific region or geographical area. The benefit of such regional benchmarking is that it recognizes the differences inherent in various geographical areas. For instance, some EMS benchmarks in the Metro Milwaukee area would be very different from those in rural northwestern Wisconsin. Average response times would be one such example. On the other hand, regionalization of benchmarking does not necessarily mean one area is destined to be identified as providing low quality of care. The benchmark for adherence to approved protocols, for instance, could be just as high in rural areas as it is for services in densely populated areas. Within EMS, quality can mean a few different things. For instance, it can relate to customer service and the patient's experience. It can also refer to the level of service provided. For the purposes of this discussion, however, we will define quality simply as operating without errors. Any EMS agency that wants to maintain a high level of quality must identify and employ techniques to reduce errors. Within this definition of quality, there are 4 general categories of error: diagnostic, treatment, preventative, and other. A diagnostic error includes any error or delay in diagnosis of the patient's condition, a failure to employ resources, or a failure to act given diagnostic results that would precipitate such action. Treatment errors commonly include mistakes in the performance of a procedure or test, or in the performance of interventions that are not indicated for the patient. Preventative errors are those that fail to implement a prophylactic treatment that could prevent the medical problem or injury in the first place. Inadequate monitoring or follow-up of treatment would also fall in this category. Lastly, there are other errors that do not necessarily fall into the previous 3 categories, but are just as important. Some examples include communication errors, equipment failure, or some type of system collapse. Ultimately, we know, based on an Institute of Medicine report, that the majority of medical errors do not occur as a result of healthcare provider recklessness. Actually, errors are commonly caused by faulty systems, processes, or conditions that lead people to make mistakes or fail to prevent them. Going back to one of our previous scenarios, this is the case where the EMS service stocks different medications in similar-looking packages. The EMS provider does not intend to use the wrong medication, but the system utilized for the storage of the medications makes it easy for good employees to make a mistake. Thus, it is recognized that placing the blame for an error squarely on the shoulders of an individual EMS provider typically has little impact on error prevention or making the overall system safer. True, there are occasions where coaching a provider may be necessary to improve the overall system, as that provider is a piece in the larger system, but focusing solely on the provider in most cases will not fix the underlying problem. It is like treating a symptom without addressing the underlying cause. The symptom will keep reappearing until the underlying cause, the root cause of the error, is identified and addressed. As employed in other critical high-risk industries, effective quality improvement systems require a knowledge of what types of errors exist so that a root cause analysis can be performed to address the underlying causes of the errors. While some errors may appear obvious, others are more subtle, and EMS leadership may not be aware of their existence or potential to exist. To be fully effective, quality improvement systems must have a mechanism by which stakeholders, employees in particular, can report quality events, which also includes the proverbial near misses as well. Even if an error does not actually occur, the mere existence of circumstances that may have led to an error, save for some type of good fortune, is important to capture, lest the next time the circumstances arise, the agency may not be so lucky as to avoid the potential error. These event reporting systems are routinely classified as either mandatory or voluntary. While it might initially make sense for an employer to mandate the reporting of any recognized quality issues, such mandatory reporting systems can have some downfalls that diminish their effectiveness. First, some of these systems wind up being punitive in nature. Rather than focusing on the system itself, the individual reporting the quality issue can become the focus of the employer's investigation into the issue. As a result, self-reporting does not always occur. The employees are fearful of retribution or, for lack of a better phrase, getting themselves into the proverbial hot water. In addition, such mandatory systems often focus on accidents and errors that have actually happened. Thus, the harm has already occurred, and the employer never had the opportunity to take affirmative steps to prevent the accident or error. Near-miss data is routinely not collected, which eliminates a large quantity of potentially helpful data from the employer's quality activities. As an indication of how important this near-miss data can be, the Institute of Medicine has reported that near misses occur 300 to 400 times more often than actual adverse events in medicine. Having a system that includes near misses is very important to proactively prevent quality issues before they happen. In contrast, a voluntary reporting system will typically garner greater acceptance as such systems are routinely non-punitive in nature. This results in the capture of more errors than in a mandatory reporting system, as the focus is on improving the system itself as opposed to simply blaming the EMS provider for errors. Such a voluntary system also allows for the inclusion of near-miss reporting, which significantly increases the amount of data that can be analyzed to proactively prevent quality issues. As a matter of fact, near-miss data is considered so important to system improvement activities that there are several national systems in place for the reporting of near-miss data. These include the Medical Errors Prevention and Reporting System, operated out of the University of Pittsburgh Center for Emergency Medicine, the EMS Close Calls website, operated in conjunction with the International Association of Fire Chiefs and the Firefighters Close Call website, the National Firefighter Near-Miss Program, operated by the International Association of Fire Chiefs, International Association of Firefighters, and the Fire Act Grants Program, and the EMS Voluntary Event Notification Tool, developed in 2013 by the Center for Leadership, Innovation and Research in EMS, with sponsorship from the North Central EMS Institute, National EMS Management Association, Emergency Medical Services Chiefs of Canada, National Association of EMTs, and National Association of State EMS Officials. More information on these various programs is included within the textbook. One thing to keep in mind about quality improvement systems is that an effective system requires the cooperation and buy-in of the agency's employees. As just discussed, voluntary compliance and participation is typically better than when an employer mandates the employees to report. Thus, it is important for employers to recognize internal quality and service measures related to its employees. Believe it or not, personnel relations are considered a key quality indicator. Essentially, the agency's employees are viewed as an internal customer in this respect. Leadership should periodically seek feedback from their subordinates. It is also important to ensure your employees are treated fairly and equally. Along these lines is something referred to as a just culture. Simply stated, if your agency has a just culture, it assumes that every employee wants to do the right thing. If a medical error occurs, for instance, rather than seeking to place blame, a just culture organization assumes the employee never meant to make the error, and it digs deeper to identify system problems that precipitated the error. While it is true that there may be cases where it is ultimately determined that the employee is indeed subject to discipline for bad actions, the initial assumption is that the employee was functioning with integrity until proven otherwise. It is somewhat synonymous with the innocent until proven guilty doctrine employed by our criminal justice system. Beyond maintaining a just culture, progressive EMS agencies strive to provide personal development opportunities for their employees. Such activities serve two functions. They assist the employee in increasing his or her knowledge and skills while preparing him or her for future career opportunities, and they also assist the employer with succession planning by helping to ensure a supply of qualified internal candidates for promotable leadership and management positions within the organization as others leave for various reasons. True, some employees are more amenable to pursuing continuing education and development than others, but the opportunities should be available to all employees within the organization, not just a select few. Ultimately, being an EMS provider is a very stressful job, and while tangibles such as salary and benefits can help attract and retain good, qualified employees, many employees are motivated by intangibles associated with their job, such as a fun and challenging working environment, or having close friends at work. As a result, EMS agencies should attempt to make the workplace fun when possible and appropriate. Along similar lines, it is also important to recognize your employees for a job well done. Such recognition, whether through a formal program or an informal interaction with a supervisor, can go a long way to bolstering employee satisfaction. Remember, your employees are your most valuable asset. Good or bad employees can make or break an organization. Hiring the right people and supporting them throughout their employment with your agency are vital steps to supporting overall quality within an EMS organization. The focus on employee health, wellness, and satisfaction ultimately ties into the quality of healthcare provided to the agency's ultimate customers, the patients they treat and transport. Happy, competent employees are the best ambassadors for any business, EMS agencies included. They also help support quality within the organization. When talking about external customer service, it is easy to think about the patient as a customer, but EMS agencies interact with more than just the patients they treat and transport. There are other stakeholders and customers to consider, such as family members and friends of those patients, the public and elected officials, other organizations with which the EMS agency interacts, and other healthcare workers and emergency workers. In providing quality customer service, the EMS agency must keep all of those potential customers in mind. This focus on customer service ties directly into quality for the EMS agency. If the EMS agency and its providers engage in a culture of strong customer service, quality will be one of the desired outcomes at all levels within the organization. Some examples of good customer service practices include making everyone feel at home, EMS providers who smile and introduce themselves to the patient and his or her family, being courteous and going the extra mile, being professional, and dressing the part. Handling every patient with care and dignity is important, as is remembering that we are here to serve the patients and not the other way around. Sure, it may be 2 o'clock in the morning and the patient has been experiencing abdominal discomfort for 3 days before deciding to call EMS, but that does not give the EMS crew the right to treat the patient with any less dignity or respect. Doing so leads to quality issues and potential medical errors. We have all experienced both good and bad customer service. Take a moment to think about the best customer service you ever experienced versus the worst. What were the differences? What was your impression of the quality of the service provided in both instances? Are there organizations you automatically think of when asked about quality customer service? What organizations jump into your head when asked for an example of bad customer service? As a leader manager within an EMS organization, you want customers to think of your agency as providing good customer service, as such customer service is oftentimes a reflection of quality. Among other things, providing good customer service means anticipating your customers' needs and doing what you say you will do. While it is easy to talk about customer service and quality, at some point an agency must put its proverbial money where its mouth is. The agency must be able to show, demonstrate, and prove quality. Essentially, once quality is defined, the service must then develop expectations or quality standards upon which it will be judged. Quality goals or standards can be developed for inputs, processes, or outcomes. They can be clinical or administrative. They can be applied at the level of an individual, facility, or system. They are clear statements of expected quality while performing EMS activities, and they may be implicit, understood, or explicit, written. Essentially, these standards are prerequisites for measuring quality. Having evidence-based standards is critical for fostering improved outcomes. When developing goals or standards for an EMS agency, or any organization for that matter, it is important to ensure the goals or standards are realistic, reliable, valid, clear, and measurable. A realistic goal or standard is one that can be obtained or followed with existing resources. A reliable goal or standard ensures a consistent outcome. A valid goal or standard is based on scientific data and evidence or some other acceptable objective experience. A clear goal or standard is understood in the same way by everyone without room for distortion or misinterpretation. A measurable goal or standard can be assessed and quantified. If any one of those characteristics is missing, the goal or standard must be updated or refined. Otherwise, the goal or standard will not lend itself to evaluation within a formal quality improvement system. Given these necessary characteristics for a goal or standard, it is helpful to follow a proven method when developing your goals or standards. The standards development cycle is one such process. First, it is necessary to define the area or topic for which the goal or standard is being developed. State the scope of care and identify the most important aspects of care if needed to focus your goal or standard where it can have the greatest impact. State the level at which the goal or standard is being set. Clarify the consensus process for validating the goal or standard as well as the approval process. Second, ensure those impacted by the goal or standard are involved in the development process. Having broad involvement of those involved helps in not only avoiding unrealistic goals or standards, but it can go a long way in garnering buy-in by those who will have to implement the goal or meet the standard. Third, The working group should gather information about the topic under review and other resources that can help define the key elements that should be included in the goal or standard. If similar standards already exist, there may be no need to reinvent the wheel, so to speak. The group should be aware of any laws or regulations that would govern the topic. If there are best practices available related to the goal or standard, the group would benefit from knowing those as well. Fourth, draft the goal or standard. If multiple goals or standards already exist or are being developed, the formatting should be consistent across the various documents. Fifth, test the goal or standard. This means reviewing the goal or standard through various scenarios to assess the reasonableness of the goal or standard. This testing informs the wording and presentation of the goal or standard, improves the quality, increases credibility, and continues the consensus building process. Following an evaluation of a field test, any necessary revisions should be made and the goal or standard should be tested again. Repeat this cycle until no further revisions are required. Lastly, communicate the goal or standards to everyone within the organization. While this is the last step, it is by no means the least important. To the contrary, all of the previous work on developing a goal or standard will be for naught if the agency does not communicate the goal or standard effectively. If conducted correctly, the standards development cycle should result in a goal or standard that supports quality design principles. Such principles seek to identify patient and public needs and design service processes with key features to meet those needs. Thus, goals and standards should be developed with the patient's and public's needs, desires, and expectations in mind. Although quality design is often applied to the development of a new process or service, it may also be used to substantially redesign an existing process or service. To assist healthcare organizations in their quality improvement initiatives, the Joint Commission publishes a 10-step systematic approach to quality design. 1. Select the process to be designed or modified. 2. Define the objectives or aims of the new process. 3. Identify the customer, patient, and stakeholders of the selected process. This includes both internal as well as external stakeholders. 4. List and prioritize the patient's needs and requirements. 5. Create a flowchart of the new process with main activity blocks. 6. Link the patient, customer, and the public's needs with each activity block in the flowchart. 7. Identify key features in the new design that respond to priority needs and requirements of the patient, any other customers, and the public. Link these key features with the flowchart's activity blocks. 8. Design the new process incorporating those key features. 9. Test the new design for robustness, meaning the design is reliable and feasible. 10. Plan, implement, and monitor the new process. Again, this is just one of many systems that can be used to support quality design within any quality improvement system. Given the adaptation of this 10-step process specifically to healthcare by the Joint Commission, however, this probably is not a bad model to follow. Looking further into how quality is defined within or by an EMS organization, it is also necessary to define a Sentinel event. Sentinel events are those unexpected occurrences involving death or serious physical or psychological injury. A serious injury includes the loss or function of a limb. If there is also risk of death or serious injury, that too qualifies as a Sentinel event. There are essentially the oh no, gut-wrenching events that no one wants to see in a patient care setting where a lapse in quality results in harm to a patient. In keeping our internal customers in mind, Sentinel events can also occur within the workplace setting to employees. Given the seriousness of such events, an immediate investigation and response is required. Because these events also recognize the probability of an injury occurring given similar circumstances, a bad outcome need not necessarily result for a Sentinel event to occur. A return to the same address by an EMS unit within 24 hours of an original call would qualify, as would a property damage-only vehicle accident involving an ambulance. The textbook does provide additional examples of instances that point to a possible loss to the EMS agency or a catastrophic outcome. When a Sentinel event occurs, an analysis and action plan to correct the cause should occur within 7 to 14 days of the event. To assist EMS agencies in their quality improvement activities, the EMS Performance Measures Project was concluded in 2006 to provide an additional tool with which to gauge and report the environment and performance of EMS agencies and systems. Coordinated by the National Association of State EMS Officials in partnership with the National Association of EMS Physicians, with the support by the National Highway Transportation Safety Administration and the Health Resources and Services Administration, this tool offers improvement through common measures comparable nationwide, regardless of service sponsor type or system configuration. The goal of the project was to determine whether a common set of specifically defined measures was desired by the EMS community, and, if so, what those measures would be. Several attempts have been made to establish these standards nationally, and there are several other proposed standards out there from other entities, such as the International Association of Firefighters, the National Fire Protection Association, and the Committee of Accreditation of Ambulance Services. Given this lack of consistency across various national bodies and regional variations that impact such standards, it is important for EMS agencies to adopt goals and standards that make sense for them as part of a continuous quality improvement program. Given the information provided within this chapter, consider again the scenario provided earlier for the sickle cell patient assumed to be a drug seeker. Within that scenario, the key indicator of customer satisfaction failed. For this type of patient, quality must be defined using both clinical as well as business process indicators. The clinical indicators included pain control and the treatment of the patient's shortness of breath, while the business indicator was the patient's level of customer satisfaction, which was arguably low. The fact another unit responded back to the patient's residence within 24 hours for the patient's ongoing complaints would also be considered a Sentinel event worthy of more investigation. Ultimately, errors in diagnosis and treatment occurred in this scenario. In identifying possible solutions to prevent a reoccurrence of this error, the service should probably work on developing a key indicator or protocol for a sickle cell crisis as a general item, or creating a detailed option to query sickle cell events using 2 generic indicators for shortness of breath and the use of pain control medications. Such an indicator could help identify the level of care or the performance of the organization as it relates to this particular type of error. To conclude this chapter, EMS agencies must incorporate quality initiatives into their strategic plans. Those agencies must also establish benchmarks to measure quality. Adverse and Sentinel events must be defined, and standards must be created with performance indicators to highlight the details of the appropriate or applicable standard.